Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering sodium. Now, this video on sodium, both hyper and hyponatremia, it's going to be part of a multi-part series of lab values. So you guys can know what it means when these values are high, when it's low, what the nursing implications are, your nursing interventions, your teaching, all of that. Now, before we get started, as always, I'm going to ask you to support me and support this channel by liking this video. Press that red notification button so you'll be notified every time a new video is released, and subscribe to my channel if you have done so already. Don't forget, I'm now providing next generation NCLEX review. It's more like a booster because it's a 2-hour course, but in those 2 hours, I get to the meat and potatoes. You know this. I'm going to go over the types of questions you should expect, how to answer these questions, how to figure out what the answer is, even if you don't know what the answer is, and how to pull out the most relevant information. So be sure to check out the availability and get your booking on my website at nexusnursinginstitute.com. If you're currently a nursing student, you're still in the program, you're not studying for boards yet, but you're studying for quizzes, exams, final, midterms, whatever that is, and you need a boost, you need a really high grade on your next exam to move on, go to my website, check out the audio lessons I have available for you. I give you the meat and potatoes of the most important things you are expected to know on your exam. Again, my website, nexusnursinginstitute.com. All right, guys, without any further ado, let's get started. Sodium. What is the normal range for sodium? Is it 135 to 145, 3.5 to 5, 9 to 10.5, or 70 to 110? What is the normal range for sodium? Very good. Normal range for sodium is 135 to 145 milliequivalents per liter. So what are these other numbers? 3.5 to 5, that is your normal range for potassium. 9 to 10.5, that is your normal range for calcium. 70 to 110, that is your normal range for glucose, fasting glucose, by the way, but glucose nonetheless. But when it comes to 135 to 145, that is sodium. So with that being said, if your normal range is 135 to 145, anything higher than 145 is considered hypernatremic, and anything lower than 135 is considered hyponatremic. Now, guys, depending on the textbook or the lab, the numbers may differ by 1 to 2 points, but I promise for testing purposes, it will be way out of range if it needs to be, that you'll know the difference, okay? So anyway, sodium 135 to 145. Select all that applies. What are the risk factors for hyponatremia? Select all that applies. The risk factor: excessive GI losses, renal losses, SIADH, NPO status, excessive use of diuretics, hyperglycemia. And remember, guys, when it comes to select all that applies, just treat it as true or false. Pick what you think the risk factors for hyponatremia would be. I know some of you guys are going to cheat by looking at the picture, but that's okay. As long as you're learning, that's all I care about. Okay, so let's talk about this. All of these are risk factors. First one, excessive GI loss. So we know that hyponatremia is having low sodium, less than 135, right? Right. So how are they losing the sodium? One of the ways they could be losing the sodium is, let's say that patient has diarrhea, right? They have diarrhea and they're losing all these fluids through their stool. They're also going to be losing sodium. That can cause hyponatremia. Renal losses. Well, how? If the patient's urinating a lot, let's say a patient's on diuretics, they're losing a lot of their fluids through the urine. Guess what's coming out with the fluids? Sodium. That can cause hyponatremia. SIADH, I just did a teaching when I did the Kahoot on endocrine over SIADH. Remember, that's when the patient has too much anti-diuretic hormone, right? So what happens is they've got too much anti-diuretic hormone, so they're holding on to all their fluids. But guess what? The little bit of urine that they do let go of, just the tiny bit that they let go of, are full of solutes, including what? Sodium. So that sodium that should have been hanging out in the bloodstream, increasing the serum osmolarity, is coming out in the urine, increasing the urine gravity. Yep, SIADH is a risk factor. NPO, it makes sense. Why does it make sense? Why does it make sense? Because if the patient's not eating anything, they're not going to be consuming any foods that have sodium in it, and that can cause them to be hyponatremic. Excessive use of diuretics. Well, I already explained that. If you're taking diuretics, you're urinating a lot. You're urinating a lot, you're losing sodium in your urine. And last, hyperglycemia. What are those three signs of hyperglycemia? Polyuria, polydipsia, polyphagia. Poly what? Urea, urinating all over the place. Guess what comes out in the urine? Sodium. So all of these things can cause the patient to be hyponatremic. Select all that applies. What are the clinical manifestations of hyponatremia? Select all that applies. Muscle weakness, decreased deep tendon reflexes, muscle spasms, hypertonic deep tendon reflexes, hypotension, hypertension. How are you guys doing on the live? Keep putting your answers in. Okay, let's go over this. So the signs and symptoms of the sodium being too low. Before we go over these signs and symptoms, you need to understand that sodium is very important for nerve and muscle function. So imagine what happens if the patient doesn't have enough of it. Yeah, they're going to have muscle weakness. The deep tendon reflexes, they're going to be decreased, not increased. They're going to be very slow. Muscle spasms, no. I just told you that sodium is important for the nerves and muscles. So you don't have enough of it. You're not going to have the increased muscle spasms. You're going to have the muscle what? Weakness. You're going to have the opposite. So no to muscle spasms. Hypertonic deep tendon reflexes, nope. Those reflexes are going to be decreased. Hypotension, yes. And let me explain to you why. Fluid goes everywhere that sodium goes. And that's why people with high blood pressure shouldn't be eating foods high in sodium, because fluid follows sodium. So the more sodium you have in your body, the more fluid you're holding on to, the higher your blood pressure is going to be. So if you don't have enough sodium, what do you think your blood pressure is going to look like? The opposite. It's going to be low. You're going to be hypotensive. So yes, to hypotension, but no to hypertension. Hypertension, you see this with what? Increased sodium. You see that with hypernatremia. So the correct answers for hypo is going to be your muscle weakness, your decreased deep tendon reflexes, and your hypotension. True or false? If a patient has severe hyponatremia, a hypertonic solution is expected to be ordered. Is that true or is that false? If they're hyponatremic, you expect for a hypertonic solution to be ordered. True. Think about it. If the patient has hyponatremia, the sodium's low, you're going to want to give them fluid that's full of solutes, Something like sodium chloride. So if the patient is hyponatremic, you expect a hypertonic solution to be given. True. Very good. Select all that applies. Which is not a nursing intervention for hyponatremia? Which is not a nursing intervention for hyponatremia? Select all that applies. INO and daily weights, fluid restrictions as ordered, sodium restrictions as ordered, encouraging high sodium foods like cheese, milk, condiments, monitoring respiratory status, encouraging the patient to change positions quickly. Which ones would you say are not nursing interventions for hyponatremia? Okay, let's go over the actual nursing interventions that you would do for the hyponatremic patient, which we're not looking for. That's not the answer, but I just want to go over those first. Patient that doesn't have enough sodium, they're hyponatremic, we're going to do INOs. We want to know how much fluid is going in and how much fluid is going out. We're going to want to do daily weights. And let me be specific with those daily weights. You're going to be doing daily weights in the morning, before they have anything to eat, same type of clothes, same type of scale. Okay, that's how you do the daily weights. Also for the hyponatremic patients, fluid restrictions as ordered. This patient's already hyponatremic. They already don't have enough sodium. So I want you to think about it. Professor D, all right, they're hyponatremic. They don't have enough sodium. Why possibly could they be on fluid restrictions? Don't you think they have too much fluids and that's diluting all the sodium that they have? That's called dilutional hyponatremia, right? So we're going to be concerned about that. So yes, fluid restrictions as ordered. We're going to do that. That's going to be a nursing intervention. Another nursing intervention, remember the sodium's low. So we'll encourage high sodium foods such as cheese, milk, condiments such as what? Ketchup. Ketchup's really high in sodium. Also monitoring the respiratory status. Remember that the patient who's hyponatremic is going to have muscle weakness. Well, guess what? You have accessory muscles and you have muscles that you use for respirations. So do we care about anything else if our patient's not breathing? No. So absolutely, we're going to be monitoring that patient's respiratory status because we're concerned about that muscle weakness. All of these are appropriate nursing interventions. Now we have two nursing interventions that are not appropriate for the hyponatremic patient. What is it? Sodium restrictions. Why would we put a patient who is already hyponatremic on sodium restriction? That makes no sense. They need sodium. We don't need to keep them away from it. And the other one is encouraging the patient to change positions quickly. You see that word quickly? That's what made it wrong. And I preach this to you guys all the time. I don't care how beautiful an answer choice looks. If there's one word out of that whole answer choice that's wrong, guess what? The whole thing is wrong. Throw it out. We know that a patient who's hyponatremic, they're gonna have what? Hypotension, low blood pressure. They're at risk for having orthostatic hypotension, where they move, the blood pressure drops, right? So what are we going to teach that patient to do? We're going to teach them to dangle, and we're going to teach them to change positions slowly, not quickly. All right, let's keep going. True or false? Hypernatremia can cause disturbances to the endocrine, neurological, and cardiovascular system. Is that true or is that false? We're switching gears now. We're talking about hypernatremia. Can it cause disturbances to the endocrine, neurological, and cardiac system? True, absolutely. And you'll find out in just a few slides how it can affect, but yes, it affects all of those systems. Select all that applies. What are the risk factors for hypernatremia? Select all that applies. Water deficit, NPO, IV hypertonic fluids, kidney failure, Cushing's disease, diabetes insipidus, fluid loss. All of them. So let's go over this. Now, we're talking about hypernatremia, which means that the sodium is higher than 145. Remember, your normal range is 135 to 145. Less than 135, you're hyponatremic. More than 145, you're hypernatremic. So the patient's hypernatremic, what are the risk factors? Not having enough water. Just like when the patient was in fluid overload, they had too much fluids, it was able to dilute the sodium and the sodium would be low. Well, the opposite when the sodium's high. If they don't have enough fluids, if the patient's dehydrated, you can see that sodium increase. That can cause hypernatremia. If the patient's not, well, I'll get to that. Next, IV hypertonic fluids. If this patient's getting a whole bunch of fluids with sodium in it, guess what? It's going to increase that patient's sodium levels. Kidney failure. The kidneys are responsible for excretion of the waste that were in the blood, right? And it comes out via urine. So I want you to think about this for a second. If your kidney's not working the way it's supposed to, you're not urinating the way you're supposed to. And remember, the sodium comes out of the urine. You're holding on to all of that urine, which means you're holding on to all of that sodium. That'll cause hypernatremia. It makes sense. Cushing's disease. What do I always tell you guys about Cushing's disease? I want you to remember these three things. Too much salt, too much sex, and too much sugar. Too much salt, that's your mineralocorticosteroids the patient has too much of. Too much sex, that's your androgen hormones. And too much sugar, that's your glucocorticoids. So obviously too much salt, that'll cause hyperglycemia. Yes, absolutely. So Cushing's disease can be a risk factor for hypernatremia. Diabetes insipidus. Diabetes insipidus is on the opposite end of the spectrum. Remember when we were talking about SIADH, the patient had too much antidiuretic hormone, they were holding on to all of their fluids, it was causing hyponatremia. Well, diabetes insipidus is the opposite. They don't have enough ADH, so they're urinating all over the place. All over the place. But remember what we talked about when it comes to diabetes insipidus and what's the other one called? SIADH. So in diabetes insipidus, even though that patient, the urine output is high, they're urinating all over the place. Guess what? The urine specific gravity is low. That urine is very dilute. You want to know why? Because even though they're urinating a lot, all of the solutes, including sodium, is staying where? In the blood. So that's why you see the serum osmolarity increase, urine output increase, but urine specific gravity decrease. So absolutely, diabetes is a risk factor for hypernatremia. Why? That sodium is not leaving with the urine, it's staying in the bloodstream. And of course, last, fluid losses. You know, if the patient has fluid loss from whatever, they could be whatever angle they're having the fluid loss from, I want you to think of fluid loss in terms of the patient being dehydrated. Dehydration will cause hypernatremia, just like fluid overload, which is the opposite of dehydration, can cause hyponatremia. So if the patient loses too much fluids and they're dehydrated, that can cause hypernatremia. So all of these are risk factors for hypernatremia. Select all that applies. I know you hate them, but this is how you learn. What is not a clinical manifestation of hypernatremia? Select all that apply. Dry and sticky mucous membranes, tachycardia, muscle twitching, irritability, seizures, abdominal cramping. We want to know which is not a clinical manifestation of hypernatremia. Oh, I made a mistake. I'm so sorry, guys. I should have taken out the not. It should have been which are clinical manifestations of hypernatremia. Let me take a look. Dry and sticky mucous membranes, that absolutely is a manifestation of hypernatremia. So sorry, guys. Tachycardia, yep, that's a manifestation. The reason why, think about it. If the patient's hypernatremic, most likely the fluids are low, right? So that heart rate is going to increase because it's trying to push what we don't have. Okay, we're going to see tachycardia, muscle twitching. Yep, remember in hyponatremia, those muscles were just relaxed and flaccid. We're going to see the opposite in hypernatremia. Irritability, yep, because remember, it doesn't only affect the muscle, it affects what? The nerves as well. Seizures, absolutely, for the same reason, and abdominal cramping. I'm so sorry. I know I'm messing up who wins, but all of these are signs and symptoms of hypernatremia. I promise, guys, I'm going to double check next time I make a Kahoot for you. Please forgive me. I'm sorry. Everyone's a winner. Everyone. All right, select all that applies. Which two types of fluids may be ordered for hypernatremia? So you're going to pick two. What two types of fluids would you expect to be ordered for the patient that is hypernatremic? Would it be a hypertonic solution, a hypotonic solution, isotonic solution, 3% sodium chloride, 5% sodium chloride, or, Professor D, I have no clue. I need to go study this. What two fluids do you think will be ordered for hypernatremia? You guys did a great job. Most of you chose the correct answer. So if the patient has hypernatremia, we're going to try to get a fluid that's low in solutes, right? We want a hypotonic solution, yep. Or isotonic, absolutely. Not hypertonic. This is going to make the hypernatremia even worse. And definitely not 3% sodium chloride, 5% sodium chloride. So the two that you give would be hypotonic, isotonic. True or false? Water intake should be encouraged in the patient with hypernatremia. Is that true or false? Very good. True. They've got all this sodium. We're trying to dilute that sodium. So we're going to encourage the patient to drink fluids. Absolutely true. And guess what? As they drink fluids, they're flushing the kidneys. They're going to urinate more. And what comes out with the urine? The sodium. So that will help bring down the sodium. Very good. True or false? Sodium intake should be encouraged in the patient with hypernatremia. Is this true or is this false? Very good. This is false. The patient's already hypernatremic. They already have too much sodium. We're not trying to encourage them to get more sodium in their system. Very good. Last question. Select all that applies. What are important nursing interventions for the patient with hypernatremia? Select all that apply. Providing comfort measures to decrease thirst, monitoring their INO, reporting any urine output less than 30 milliliters per hour, encouraging oral fluids, giving a low salt diet as ordered. I give up. I have to go study this. What do you guys think? I see the typing slowed down on live. I know you guys hate select all that applies. This is how you learn though. I promise. Okay. Two people said I give up. Okay, so let's talk about this, the nursing interventions. Patients, sodium is too high. You're going to provide comfort measures because remember, they're going to have that dry, sticky mucous membranes. They're going to be very thirsty. You're going to give comfort measures. You're going to monitor their input and output. You're going to report any urine output. Let me tell you something. The adult urine output is supposed to be at least, at the minimum, 30 mLs per hour. Let me tell you what happens whenever someone's severely dehydrated or anything's like severely wrong with the body for that matter. Your kidneys are the gatekeepers. They're the first ones to shut down. So if you see that urine output less than 30 mLs per hour, that patient, something's going on with them, and most likely they're severely dehydrated. You're going to have to notify the healthcare provider. You're going to report any urine output less than 30 milliliters per hour. 30 mLs per hour is your key. That's a minimum that we want to see in an adult. We're going to encourage oral fluids because we want to flush those kidneys. We're trying to get the sodium out and give a low sodium diet as ordered. They've got too much sodium in their system as it is. They don't need to get it through food. So that is important nursing interventions for your patient with hypernatremia. You guys did such a wonderful job. Guys, thank you so much for watching. Thank you for your participation. Please please don't forget to go ahead and let me know in the comment section which videos you'd like to see me cover more of, what content you'd like to learn more about, and the format that you'd like to see it in. Do you want to see it in a Kahoot? Do you want it to see it in my traditional lecture? Do you want it to see it in, do you want to see it in like a question format, like the kind of videos I do that are released on Sundays at 1 p.m. Eastern Standard Time? Let me know in the comment section. Also, one more thing I want to bring to your attention. Almost daily, you guys can find me covering a variety of nursing topics on my other social media platforms. So be sure to check that out. TikTok, where am I? I'm on TikTok, Instagram, and YouTube. I'm sorry, I had a brain fart. Guys, thank you so much for watching. You guys will catch me on the next video.